All right, well, let's get started. People will probably still trickle in here, but thank you all for joining us this evening. We're so excited to have Karen Ashforth with us, an expert on fibrosis, here today to talk about assessing and treating fibrosis for the lower limb with lymphedema and wounds. So with that, I'm going to hand it over to Karen, but Eleanor is so pleased to have you here, Karen, and really looking forward to your presentation. And as people have questions for you, we can have them drop them in the Q&A and we will take care of those at the end. So with that, I'll hand it over to you. Thank you, Karen.
Thank you so much. I'm just so honored to be invited to speak tonight. And fibrosis is really a huge passion of mine. Just a little tiny bit about my background. I've been an occupational therapist for over 40 years, and the last 20 I've specialized in the treatment of lymphedema and lipedema. And I started to really hone in on fibrosis, oh gosh, 10, 12 years ago. It really occurred to me that as I was treating patients, the hardened tissues that were creating barricades to lymphatic flow, as I addressed those, my patients started having better spontaneous lymphatic circulation. And while I don't think I can claim to put all of my patients in remission, I think that there's a huge amount of help that we can give our patients in terms of treating and addressing this fibrosis that is such a huge factor in lymphedema and lipedema. So with that, I want to go ahead and start my presentation, and I want to just acknowledge L&R and thank them for inviting me to speak. It's just been a pleasure to put this webinar together, collaborating with L&R. And let's talk about our agenda. For those of you who may not know, I'm going to just briefly cover what fibrosis is, and then we're going to start to identify different types of fibrosis that we see in the lower extremities and concurrent with wounds. I'm going to give you a little overview of the different types of treatments that are out there for fibrosis, and I'm going to give a special nod to treating dermal fibrosis. We're also going to look at anti-fibrotic compression solutions, and there's way more information about treatment than I can give you in this time. So we're going to be focusing in on the area of compression, which we use to treat lymphedema anyway. So why not make our compression anti-fibrotic so that we can treat the fibrosis as well? So how could this be relevant to your practice? When you treat fibrotic restrictions, you can help your patients meet their rehab goals in terms of decreased pain, decreased swelling, increased range of motion, increased strength and endurance, increased mobility and function, and improved overall treatment success. So let me just show you visually some patients that have pretty complex fibrosis in the lower body. And have you ever seen patients like this? And what have you done in the past? My hope is that I can give you tools that you can use in your toolbox that you can start using even tomorrow in the clinic to help patients. So let's just talk a little bit about fibrosis in general. I was shocked when I learned that fibrosis is present in all lymphedema patients. They can have many different types of fibrosis all at the same time. And fibrosis actually determines lymphedema staging. It is an important and overlooked component of lymphedema treatment. Lymphedema itself contributes to fibrosis. So let's talk about fibrosis, what it is. It's an inflammatory process where damaged tissue is replaced by hard, dense, thick masses of tissue. And it can be collagen, fat, or mixed in nature. When we look at lymphedema staging, we notice, this is a very packed slide. So I want you to start by just looking at the white letters. Those are the stages of lymphedema. So from stage 0 to 3, I'm using the Foldy's classification. Now, if you look at the amber color, you can see that even in the latent stage, you're already getting focal fibrosclerotic tissue changes, which advance with each stage. By the time you get to stage 2, which is irreversible, you're already getting adipose deposits. And that's why stage 2 is irreversible, is because in addition to swelling, in addition to the fibrosis, you're getting adipose mixed in with the fibrosis. By the time you get to stage 3, if you see the green, you're getting dermal changes, which we'll go over in loving detail. Just to make it a little more clear, I'd like to go stage by stage. So starting with stage 0, the swelling is measurable only electronically or with imaging because it's not visible, it's not palpable, there's a negative stemmer sign, and the patient may notice some heaviness or fullness, but even here, fibrosis is starting. When we get to stage 1, which is reversible with elevation, we can measure the swelling with a tape. It's visible, it's palpable. In this stage, it's usually soft and pitting, and there's usually a positive stemmer sign, and usually it will reduce fully with elevation. But if it continues to advance, we get to stage 2, where it is irreversible. And this is where the swelling continues to be measurable, but now there are palpable fatty areas that might feel kind of like silicone is kind of how I phrase it. It's firmer. There may or may not be pitting because the fibrosis hides some of that swelling. And there can be a positive stemmer sign, but it does not fully reduce. By the time we get to stage 3, this is very difficult to treat, as you all know. This is also where we see a lot of skin changes and massive fibrotic adipose deformities, such as a pannus or lobules. So when we look at all of the stages together, we go from minimal swelling to soft pitting swelling to the formation of the fatty fibrosis to huge deformities. So now let's talk about some different types. And this patient is someone that has several types. She has lymphostatic fibrosis, which is the type that we were just talking about. It's the type of fibrosis that's formed as a result of lymphedema. And I'll go over that more in my next couple slides. In addition to the lymphostatic fibrosis, she has surgical and traumatic scarring. You can see some plaques, which indicate post-cellulitis fibrosis. She does not have post-thrombotic fibrosis, although I do have patients who have had that. And she does have the lipodermatosclerosis because she has the characteristic inverted champagne bottle legs. She's developing dermal fibrosis. She doesn't currently have wounds, but she has in the past, and we treated peri-wound fibrosis. Other types that are common in lower limbs could include massive localized lymphedema, lipedema-related fibrosis, and less commonly are the radiation-induced fibrosis. So let's go back and talk about lymphostatic fibrosis. And this is a very severe case. You can see this is not just swelling. He's got huge fatty deposits in his toes, his foot, his legs. And lymphostatic fibrosis can be a hard or soft fatty tissue that does not fully reduce and is present in all stages, but as I mentioned, 2 and 3 are irreversible due to this type of fibrosis. And the inflammatory process responsible for this is where the lymph stasis, which is composed of the high protein extracellular matrix, attracts fat cells and forms a fatty matrix. So this is forever fibrosis unless there's some type of intervention such as liposuction. And we can manage it though, so that we can soften it and help the circulation around it. Moving on, we're going to talk about surgical or traumatic scarring. And the scar is very important because it restores the outer barrier of the body and it prevents further injury or infection. In normal healing, we have a thin epidermis, a flat basement membrane, and the collagen bundles are parallel to the skin. There's some research that is taking place looking at inhibiting fibroblast activity to decrease the scar. Some patients just genetically have thick, ropey keloid scars. Everyone is different. There are things that we can do that can influence scar healing, but that's for another lecture. Something I see a lot in my practice is post-cellulitis fibrosis. And this is a vicious cycle because, boy, if someone has a cellulitis infection and they have lymphedema, that is a deadly combination for repeat cellulitis. So when there's an infection, there's a mechanical insufficiency, which cascades into a combined insufficiency. We get dead cells as the antibiotics do their work, and it creates a sterile inflammation, and the infectious waste forms a dense, woody plaque at the infection site. If there's ineffective decongestion, it snowballs into repeat infections because this thick plaque inhibits circulation and creates a progressive fibrosis formation. Here's another example of lipodermatosclerosis. And it's very common in chronic venous insufficiency. The venous system is damaged. There's valvular reflux, which creates a stasis, vascular calcifications. You can see the fibrotic bands creating the tiny ankles and then the large calves, which has been likened to an inverted champagne bottle or an inverted bowling pin. We're going to talk quite a bit about dermal fibrosis because this is a very prevalent problem in a lot of patients who have lower extremity lymphedema. This is an example of hyperkeratosis, where there's an overproduction of keratin in the dermis, and the lymphatic damage disrupts the dermal circulation. So the cause of hyperkeratosis is from lymph stasis and the inflammation that results. You can also have problems with repetitive injury, such as friction of clothing or even compression garments. Aggressive soaps can contribute to this. This can even be a chemotherapy side effect. And hyperkeratosis increases people's vulnerability to wounds. Another form of dermal fibrosis are papillomas, which are benign nodules. They can range in size from little warts to even the size of a finger. And these can progress to form malignant tumors, which are called lymphangiosarcomas. When it's really, really tiny, and you can see some of that example in this illustration here, it's called papillomatosis, which has a mossy or sandpaper presentation. And this is frequently accompanied by lymphorrhea, which is that clear serous discharge that is like a clear liquid fluid, and that's lymphatic fluid, and that's not a good thing because that means that there's an open wound, pinhole leak, And that can put the patient in a vulnerable place for potential infection. ENV stands for elephantiasis nostril varicosa. And this is a case where lymphedema creates a progressive cutaneous hypertrophy. And it creates a lymph obstruction, which contributes to more lymph stasis. This is where the skin is very rigid, it's non-pitting, and there's a gravity-dependent edema. And we commonly see, as you can see in this photograph, the hyperkeratotic papilla nodules with a cobblestone appearance. Lichen is where the skin becomes very thickened or leather-like, also called lichen simplex chronicus. You can see in this example, it is often hyperpigmented, and the cause is when a patient has dry skin and what's called an itch-scratch cycle, where the patient is itching the dry skin and it's creating wounds, and that's creating a thickening of the dermis. So obviously, in a lot of these cases, we're going to want to moisturize the skin. We're going to want to use topicals. Some of them are over the counter, some of them are prescription. Another example is stasis dermatitis. And this is a slide that I use a lot when I'm teaching my University of Pacific physical therapy students, because this is commonly confused with cellulitis. The actual cause is venous hypertension, which creates hypoxia, resulting in cell death. And then there are fibrin cuffs, and you can see these eczematous dermal patches. It is often depicted as redness of the skin with wounds. But if you didn't know, if you didn't see that the other leg looked exactly like this, you might suspect that this patient has a cellulitis infection. But when this occurs bilaterally, which it often does, then stasis dermatitis needs to be considered. By the way, if you suspect cellulitis, I tend to send patients to the doctor anyway, if there's a good reason to suspect it. But you know, this is a lookalike for sure. Here's an example of atrophy blanche, which is hypopigmented scarring, and chronic purpuric or vascular ulcers. This is not super common. The cause is a damaged microcirculation, and the patient ends up with decreased or absent capillaries. So that's my Hall of Fame of dermal fibrosis examples. I want to just segue from there to talk about wounds, because these guys all go together. So this is our good old venous leg ulcer. And let's talk about peri-wound fibrosis. You can see that there is this scabby fibrotic plaque around the wound. And there's also biofilm inside the wound bed. So what's happened is that there's an overactivation of macrophages and an overexpression of collagen. There's a decreased vascularization, which all of this together leads to poor nutrition and slow wound healing. So this is very serious, and it is in of itself a very vicious cycle that needs to be addressed. The biofilm needs to be debrided. The plaque around the wound needs to be softened to promote better circulation. All right, so now that we've looked at all of these examples, let's take a look at some of our assessment tools and how we can use these in assessing fibrosis. So I think the most important clinical tools revolve around skin elasticity. So our pitting tests, our Stemmer sign, and looking at tissue extensibility in general. So these three categories can go a lot to describing the fibrosis that goes along with the lymphedema. I really like Robin Bjork's classification, and I've adapted it a little bit to explain this. So she classifies tissues into 4 different types. So the first column describes those: watery, fatty, putty, and woody. So watery is the type that is the least damage. There's minimal fibrosis. Now we're just reading across the top row. The density of the tissue is soft. There's easy pitting, full reduction, and a positive Stemmer sign. So if we have a patient walk in with a watery type of tissue, they are going to be pretty easy to treat. The next category, the second going across, is fatty. And I want to just distinguish that there's different types of fatty tissue. There's the normal body fat, adipose tissue, but then there's also abnormal tissue, which would include lymphostatic fibrosis, which we covered a few minutes ago, and then SAT, which is unique to lipedema, and it's called subcutaneous adipose tissue, and it's a form of diseased fat that is unique to lipedema. And I wish that we could talk about lipedema today, but we're going to be sticking mainly with lymphedema. So when we get fatty tissue, the fibrosis can be variable. It can be just a little bit, or it can be as bad as stage 3, where we're getting those lobules and deformities. But the tissue density is still fairly soft. At this point, though, it's not as likely to have the pitting, and the reduction is going to be variable. There may or may not be a Stemmer sign. So when we've got this production of fat, then the leg might be larger, but only some of that is large due to swelling, and the other part of the enlargement is due to fat. So that's why it's not going to fully reduce. And that's why it may not pit, because some of the swelling may be trapped in the fat tissue or underneath it. The next type of tissue we're going to talk about is putty. And this is, it's a moderate amount of fibrosis, but still treatable. The tissue density is still fairly soft. So when I say putty, it's kind of like a density of silly putty. You can often get pitting with deep, prolonged pressure, and we can usually get a partial reduction. In this case, there's very likely going to be a Stemmer sign. The fourth type of tissue is woody tissue, which is the hardest type of tissue to treat. It's in the case of woody fibrosis, this fibrosis is severe. The tissue density is hard. It's non-pitting for sure, and very difficult to reduce. Also, we see a positive Stemmer sign. But I want to just shine a ray of hope here and tell you that I have had patients with woody tissue. It's been as hard as a stone, and I have been able to influence that fibrosis so that it softens and the tissue can be much more buttery-like. So when I talk to my patients about fibrosis and I explain what it is, I say it's kind of like the body making Jell-O. It starts out as a liquid, and Jell-O, as we all know, has a lot of protein in it. But in this case, the protein attracts fat cells, and at that point, it becomes more putty-like. So it's still soft and pliable, but if it progresses, it gets to the point of hard putty, which is at the point where it becomes woody. So let's talk about treatment. I have a huge toolbox because my belief is that each patient is an individual. And I don't think that there is a cookie cutter approach to treating fibrosis. I think we need to have a lot of different tools in our toolbox so that we can treat what's coming at us. So let's talk about our goals. We want to decrease the symptoms of lymphedema and fibrosis, which include pain, immobility, and dysfunction. We want to try to compensate for damage to the lymphatic system. So an example of that might be a patient with scar tissue. The scar is creating a barricade to lymphatic circulation. And if we can soften and influence that scar, then there can be better circulation and better spontaneous drainage, and the patient doesn't have to work as hard. We want to facilitate tissue remodeling and healing and reduce fibrosis formation from the get-go and influence the maturation process. We also want to empower our patients with education and tools and prevent fibrosis and lymphedema progression. So I'm here to tell you that even long-standing chronic fibrosis can change, but it might take some time, and it definitely takes effort. So what are the things that I use in my clinic? Well, they fall into 5 categories. I always address anti-inflammatory risk reduction, which we won't be able to talk about tonight, but this would be our lifestyle modifications, looking at food sensitivities, looking at drugs which might have side effects that could be creating swelling, looking at stress, all those good things. I have a lot of manual therapy techniques that I use. And again, we won't be going into all of those tonight, nor will we go into modalities. But I did give you, the next slide is going to tell you all the modalities that I use. We are going to be talking about anti-fibrotic compression garments because this is where I feel LNR has some tools that can be very helpful for treating fibrosis with our patients. And I would be remiss not to mention pneumatic compression because I feel that the combination of the anti-fibrotic compression and pneumatic compression together work beautifully to help to soften and remodel fibrosis. So just to give you a little idea of some of the modalities that I use in my clinic, I use positive pressure modalities, which would be the instrument-assisted soft tissue mobilization known to many of you as Graston. I use a lot of negative pressure, which would be like the LymphaTouch or cupping. Light therapy is something that I find invaluable. I could not survive without using my laser. And occasionally I might use thermal modalities, but in very small amounts because I don't want to precipitate more swelling. Ultrasound can be useful, especially if you have ultrasound in your clinic that you can do pulsed and you don't happen to have light therapy. Microcurrent is really fun. I've really been enjoying using that and find that that is helpful for all kinds of things, including many different types of fibrosis, especially scar tissue. Vibration, whether it's handheld or whole body vibration, those are great tools. Dry needling is something that not everyone is licensed to do. And so I refer to acupuncturists because I feel that this is a very, very powerful treatment, especially for scar tissue, that sometimes one treatment will do it. Sometimes the patient needs multiple treatments, but I've seen this work miracles. I love using silicone scar gel. There's a lot of evidence around that to help remodel scars. And then elastic and paper taping also have very, very effective uses in treating scars. So let's talk about what we're doing. Are we breaking up fibrosis or are we decongesting? What is happening when we use compression and decongestion? And I want to just borrow from Heather Hetrick. She talks about the analogy of massaging an avocado that could start out as very hard, and then it can become very, very soft. So I think that the first thing that we're doing is decongesting. And once we get that fluid layer out of the way, then we can actually get to the fatty, collagenous, scarry, hard, putty, whatever woody tissue, and start to influence that. But a lot of people feel that having pitting in the short term is actually affecting the fibrosis, and it's not necessarily an overnight process. So this is a patient of mine who has lower leg fibrosis. You can see the before picture on the left, and then she's wearing her tribute wraps. And bonus points for people who can spot on the right-hand side. I mean, look at her ankles. Compare the first and the third pictures. I mean, that really, wow. You can see how visibly, after just wearing her tribute wraps for a few hours, that's created a reduction, but you can see these little lines. That's not from the tribute wrap. What happened was that she needed a modification to her tribute wrap because she'd expanded. And so I used the Comprex 2 and made inserts so that we could still cinch the Velcro, but I wanted to have some type of an anti-fibrotic medium between the Velcro and her skin. So you can see those lines. And just to clarify, that's not fibrosis being broken down. That is pitting. That is decongestion, but it's the start to remodeling fibrosis. Let's talk a little bit about skincare, because I think that is a real key, especially when we're talking about lower body and wounds. So we know that swelling adversely affects the skin, that it slows the circulation, it weakens the immune system, it increases the wound risk, and lymphedema patients who have chronic congestion are 71 times more likely to develop cellulitis than patients without lymphedema. So it is critical that we educate our patients in proper hygiene and moisturizing practices. We talked a little bit before about the lichen, the dry skin, the itching, scratching, breakdown, and then in some cases infection. So we really need to look at making sure that our patients are moisturizing and using the right products. Thin skin, especially as people age, the thin skin really requires conditioning to prevent breakdown. So using a thick ointment or cream is way more effective than lotion. I always ask my patients, what are you using? And if they have significantly dry skin, even if they are moisturizing, usually it's because they're just using a lotion, which is water-based, and they need something that is more petroleum or oil-based. With broken skin, I really always want to recommend a prophylactic antibiotic ointment on any kind of scratches or scrapes or anything that breaks the skin. And not a lot of people are aware that the triple antibiotic ointment can cause a contact dermatitis. And so I recommend a bacitracin, which is a single antibiotic, or a double antibiotic ointment. And these are harder to find because you go into the drugstore and it's Neosporin everywhere. And some patients do fine with it, but some patients can end up with a dermatitis. So I've taken to just educating patients that, especially if you have lymphedema, especially if you're at risk for infection, if you're going to be using antibiotic ointment prophylactically on a regular basis, you want to lower your risks of getting a contact dermatitis. Another thing is that you really also want to make sure that patients that are prone to fungus are not slathering on a petroleum-based product, making sure that they avoid excess moisture and use antifungal agents when needed. Some other skin care tips for dermal fibrosis. In addition to preventing the xerosis or dry skin with the moisturizing, you want to encourage exfoliation. And I'm going to talk in the next slide about a great debridement agent. You want to avoid hot baths. And there are different topicals that can be used, such as lactic acid, salicylic acid, urea, retinoids, steroids. And in some cases, even using dandruff shampoo can be effective. So there's different evidence for different types of skincare agents. Ultimately, it's really up to the doctor. Let's talk about debridement. And I love, love, love the DebraSoft, which is an LNR product. And in some cases, if I need something that is more moisture-based, I might use Aquaphor ointment in a washcloth. There's sharp debridement, which is appropriate for calluses, corns, for that nostra varicosa that we talked about. But you're going to need to refer to your specific licensure for specific requirements. On the right are a couple of the DebraSoft pads. The Lolly is the little green stick, and that's great for going actually inside wounds. It's so good for biofilm. And then the pads come in different sizes. And again, wonderful, wonderful, wonderful for biofilm. And I can't say enough good about them. I've got a great case study where we used the DebraSoft for debridement. And this is a patient who had non-healing wounds for 40 years, who finally started to heal after using the DebraSoft. All right, we're going to switch gears yet again and talk about anti-fibrotic compression garments and the different types. Elastic, quilted are the two main types, and they can be textured to create a micro massage. They can be low profile versus a quilted, which is a little bit thicker. And the effects increase when you use exercise or more bulk or a greater class of compression or external pressure. So the advantage of the elastic anti-fibrotic compression is that it's low profile, and patients love to wear them because they're easy. They can wear them out. And some examples would be a non-medical grade of stockinette, as you can see on the left. You've got a textured circular knit in the middle, which is like an anti-cellulite garment. On the right is a medical grade flat knit, which happens to be the LNR Exo Strong. We also have chip foam pads and garments. And many of us have fabricated pads or Schneider packs in our clinics. I'm going to show you in the next slide an example of swell spots for reduction of edema and spot use on fibrosis. Also, the Caricia bandage liner is wonderful because it is the chip foam, and so you have that texture that you can bandage over. And then a Tribute Night is a custom night garment, which has the anti-fibrotic chip foam effect. And a Tribute Wrap is a ready-to-wear night garment. The anti-fibrotic and decongestive effects are tremendous. And these are definitely bulkier garments. And what I tell my patients is more is more. If I have someone with frail skin, it's going to be very, very helpful. And I'll put my patients in boot camp where we're in the reduction phase and using this chip foam as opposed to flat foam, because this is much more effective than using just the straight flat foam that's not textured. Anti-fibrotic pads, you can see on the right, top and bottom, are some great examples of swell spots that come in all different types of shapes and sizes. On the left, you can see the complex orange foam that I have made a fabricated pad. And on the bottom left is the complex 2, or we call it noodle foam in our clinic. And you can pad that up with a little extra gray foam if you want to create a little more bulk. Here's how I fabricate pads. I will use just a soft tape, and you can see on the right how I've done that with the Comprex, and on the left, I'm making a bead pack. So I'm using beads. This is very, very aggressive. This is not for everybody, and it's not something that is meant to be used day in, day out. You have to use it sparingly and cautiously and with lots of monitoring. I want to just mention that using external pressure will increase the anti-fibrotic effects. So if we look at the spectrum of effectiveness, we've got our elastic compression over on one side, which is nice because it's low profile, and it does give a nice little anti-fibrotic massage as patients are moving. And then adding something like a Ready Wrap is going to give a little bit more compression. And then the Tribute Night or the Tribute Wrap is even more. And then if you want to really get serious, you can bandage over it. And then to really, really maximize your effects, use a pump over top. So we're going to end up with some case studies. And this is one of my patients. This was a little guy who is a 6-year-old. And when he came to me, he had never worn toe caps. In fact, there's a lot that he had never done. So the first thing we needed to do was just really address the stasis by doing a very aggressive decongestion. I used a lot of laser on his toes. I used a lot of instrument work, a lot of manual work, using swell spots across the toes under the nocturnal sleeves and under the pump created a lot of massage to the tissues, and definitely using the custom flat knit toe caps was very, very helpful. So you can see before and after, he actually has daylight between his toes in the after. So unfortunately, his fibrosis was so extensive when he came to me that, you know, this is as far as we could get with it. But when he gets older, he's looking at the possibility of maybe a little bit of liposuction surgery. This is a case study from my buddy Leslie Bell in Vermont. And this is a patient who came to her. She did 7 treatments. She used the Comprex 2 at the same time as the pump, and then she followed it with manual lymphatic drainage. She also did some elastic taping on the lateral aspect of his knee to further address the fibrosis that was obstructing the drainage of the lateral leg. So you can see the before picture on the left, and in the middle, you can see those lovely lines from the Comprex 2 right after he's had his pump treatment. And on the right, this is the final result. He was able to really reduce very nicely. This is a patient who was just a nightmare train wreck of dermal fibrosis and wounds. So we needed to really heal those wounds and debride the skin. So I started with the Aquaphor and the washcloth method because it was a lot more aggressive. And then we were able to really attack those wounds with the Debra Soft. You have just a little note, you have to totally not have any aquaphor present because that'll clog up the DebraSoft. But they do different things. And the washcloth is kind of like heavy grit sandpaper, and the DebraSoft is like fine grit sandpaper. We worked really hard on reduction, and using the Rosedal TCS dual layer wound care wraps was very useful, as well as bandaging over the Caricia bandage liners. And then finally getting him into the Exo Strong daytime flat knit stockings. And in this case, as you can guess, this guy really needed to work on body mass reduction. So this is before and after. And you can see that we were able to really create a very nice reduction and debridement of his lower legs. But still, I think because of the body mass, because of the knee and upper leg swelling, he still has a long road to go. This is from my colleague who Robert Greenway shared these slides with me, and I want to thank and acknowledge him for that. This is the patient that has had wounds for 40 years. It resulted from CBI with edema. She had Alzheimer's disease and therefore had poor compliance. And the DebraSoft was only used once a week. But with that use, 2 wounds closed. And the final wound is now forming skin islands. This patient was formerly very apprehensive to painful debridement. And the use of DebraSoft, it's so gentle, it really increased her ability for wound care tolerance and thus wound healing. So this is showing you that nasty biofilm and how this was able to really create better healing for her. So we're at the end of my slides, and I would love to hear from you. If you have any questions, if you have any problem cases, if you have any anything that I spoke about that might not be clear, would love to hear from you. So at this point, I'm going to stop sharing my slides. And Lindsay, if you could go ahead and fire away some of those questions.
Yes, and so keep your questions coming in. We've got 9 right now.
Oh,
The
10.
first one, oh, no, another one. So we've got a question. I want to better understand lipodermatosclerosis.
I
That
know
is
that's a
quite a word of the
mouthful,
evening.
isn't that? Yeah, yeah. So that's very, very common with chronic venous insufficiency. And it's an inflammatory condition. And so this is something where we really need to work on that fibrin cuff around the ankle. And often it's accompanied by a lot of dermal fibrosis. So when you see that presentation, think CBI, think all the things that you would do to treat CBI in terms of, you know, your decongestion and your compression, and pneumatic compression certainly would be really, I think, a key thing also. So I'm not sure if I answered the question, but it's more common than you would think.
Thank you, Karen. Can you talk a little bit more about the issue, even when someone's on antibiotics for cellulitis? And I'm not quite sure what that is in relation to. If you have any comments for that, Karen, otherwise, if Laura, if you could add some more comments in there as well.
When I have a patient that has cellulitis, and by the way, I probably take regularly dozens of patients, and I either walk them down. I work at a hospital-based lymphedema clinic. And so I've actually walked patients to ER saying, I think you need to be seen like right now. Or if it's just kind of starting and it's someone that I think will be reliable and will go to urgent care, I'll send them to urgent care, because yes, you definitely want to get on antibiotics ASAP. And when someone is on antibiotics, my understanding is that you don't want to create sepsis. So using regular compression is great, but you really want to stop manual lymphatic drainage and pneumatic compression until they've been on antibiotics long enough for the redness to start to recede. And I don't know if you guys do this trick, but I take a Sharpie marking pen and I'll outline the actual red area of infection. And it's funny because the last patient that I walked down to ER, when he came into the clinic, I suspected an infection. So I said, do you mind if I draw on your leg? And so I outlined it. And then we did some treatment. And after the treatment, I looked, and sure enough, it was going outside the edges of the Sharpie. And it's like, okay, we're getting you over to ER. And he ended up being admitted. So yeah, you don't want to mess around with this. And I'm going to just, this is just a tangential thing, but we know that celiac and gluten intolerance is associated with primary lymphedema. And I have had a number of my patients do the gluten challenge where they will give up gluten. And these are the ones that have the repeat infections. And I've had patients stop the infection cycle by stopping gluten in their diet. And when you think about it, the abdominal lymphatics are the largest part of our lymphatic system. The majority of the lymph nodes in our body live around the digestive organs. So if someone is consuming a food that they're reacting to, that's overloading the gastric lymphatics, and it's compromising their lymphatic system as a whole and making them more vulnerable to infection. So just a little aside there. Next question.
Thanks, Karen. It's always good to have those extra tips.
Yeah.
Next one is, what is the difference between lichen and hemosiderin staining?
Oh, very good question. So lichen is actually a thickening of the skin, and hemosiderin staining is it's where the red blood cells leak outside of the veins. So basically, you've got this venous insufficiency, and the veins are distended, and you've got venous stasis, and the pressure in the veins is so great that you're actually getting red blood cells leaking outside. And it's those red blood cells, hemo blood, that are actually staining the skin. So that is one of the signs of chronic venous insufficiency, especially in a more advanced stage when you get that brownish stain. Good question.
Thanks, Karen. How do you decide with compression to go up to the knee versus up to the groin when treating edema?
Well, if I've got a patient who ends up with knee swelling, like that gentleman that you saw in the case study, I had the hardest time getting him to wear something above the lower legs. And with a lot of patients with chronic venous insufficiency, if you can compress up to the knee, then they're home free. But some patients, especially that gentleman who was obese, or someone who's had knee surgery, or someone who has had some type of lymphatic disruption above the knee, like my patients with melanoma, or, it can be even surgical scarring. There can be maybe lymph nodes removed as a result of melanoma or cancer. So I think a lot of it is trying to find what the patient will actually do. And that gentleman, he would wear his knee highs, but he would not wear thigh highs, and he would not wear knee highs with capris, which is another solution that I love to do. Sometimes what I'll do is I'll do knee highs and I will do a knee wrap. And that's a little tricky. Not everyone can do that because it really does affect the knee mobility, and not everyone likes that. So I try to give my patients the different choices, because at the end of the day, it's what they're going to wear.
Mhm. Very good point. Next one, when do you perform fibrotic techniques in your sequence of treatment during MLD as a separate treatment?
I mix it all like jazz. I mean, I do anti-fibrotic MLD. I'll do MLD while I'm doing laser. I'll do decongestion first, and then I'll get in there with the tools. It really kind of depends on the patient. So I find, though, that I have to really get a good decongestion before I can be effective at going to that deeper fibrotic layer.
Thank you. I'm going to combine a couple questions since there were some related to the laser. So what was the laser work with the child's toe that was done? And what brand did you use for that treatment? And were there any parameters? So kind of what is the work that you did? What is the brand that you typically use and the parameters surrounding it?
Okay, well, to my knowledge, there's only one instrument that is FDA approved specifically for the treatment of lymphedema in the United States, and that's the LTU 904, which is the Australian laser. And they're pretty pricey. They're about $4,000, but let me tell you, in my history of using it, which has been since it was FDA approved, I got one of the first loaner lasers. Between the two clinics that I've worked at, we've purchased 8 lasers, and I own my own because it's that powerful. So there are really no major contraindications or precautions to use. It's very safe. You just don't want to point it right at your eye. But it is eye safe. You don't have to use goggles with it. It's non-thermal, which is why it's really good for treating lymphedema. And the protocol for the use of that instrument is about 45 to 60 seconds per 2 centimeter area. So I create a grid. In other words, if this were his toe, I would start here. And then after a minute or so, then I would go here. And then I would go here. And basically just kind of work the area. I'm using the laser with one hand, and then with the other hand, I'm doing either Graston or the manual techniques, because you should know that laser is considered experimental by insurances, and so it's not a standalone modality. It does not have its own modality code, and you have to do it concurrent with something else. So with all of that being said, it's still one of the most powerful tools in my clinic.
Thank you, Karen. I'm going to consolidate a couple of these questions as well. We had a few people ask what DebraSoft is or what that green tool is for debridement, and asked if you could maybe review that and how you're using that.
Oh, great. Yes. Well, DebraSoft is a specific type of wound care debridement tool that is used a lot in wound clinics, and I think should be used more in lymphedema clinics. And it's kind of like a little it's like a gentle scrub brush. So I would describe it as, how you've got those scrub sponges that have the sponge on one side and then the scrubby part on the other side. It's like that, except it's very, very gentle. And it is very comfortable for patients and really effective for biofilm. And what I would recommend, because L&R is wonderful about supplying samples if you've never used it before, is reach out to your L&R rep and ask for a sample, because there's all kinds of research, there's educational papers, as well as the different types of samples. And I think you have to just try it to really see what it does.
Awesome. Thanks, Karen. And yes, definitely reach out to us. We'll type in our email in the chat box as well, so you can reach out to us and we can connect you to your local rep. Someone else asked, could you review the Carecia?
All right. Well, what's nice about the Carecia is that you can use it under all different types of things. It's not really compressive by itself, but it is compressive if you wrap over it, and it creates this wonderful anti-fibrotic effect. So I love it because it's easy, it's inexpensive for patients. It's something that if you've got a patient in the reduction phase and they're very fibrotic, I think it's way more effective than just using the flat gray foam.
Thank you, Karen. I know we're going a little over time. Do we have time for one or two more questions
Oh
here?
yeah, yeah, sure.
Okay. So we've got, I'm a newly certified lymphedema therapist, and I am confused about the use of IASTM. I thought that too much pressure can cause damage on the lymphatics. How do you use it effectively?
Well, I think that first off, you need to take some specialized training so that you can learn all the different precautions for it. And we're not treating normal lymphatics when we're using the instrument assisted modalities. We are treating abnormal fibrotic hard scar tissue. And I have found few things that work as fast as that modality. It really can be very, very effective, particularly on scars. So I would encourage you to check it out. There's a lot of literature written about it, and it's something that's easy to learn, easy to use. Sometimes I will teach my patients how to do it, but not everybody. Not everyone's appropriate for that. So check it out.
Thank you. I have a patient with a large pannus on the thigh with a wound. The skin is a bit thick around the wound as well. Where do we start? Can we compress over the wound?
Oh, yes, absolutely. Compression accelerates wound healing. So I would absolutely do that. So you want to dress the wound really well and then pad it up a little bit. If it hasn't been compressed before, you're going to want to use extra dressing because wounds tend to be pretty juicy if you have a lot of swelling. So that would be my suggestion, would be to just do your regular CDT bandaging and go for it, because that will definitely make the wound heal faster. And once the wound is healed, then you can start using some of those anti-fibrotic swell spots or even garments on that, and really work on that fibrosis.
Thank you. And so out of respect for Karen's time, we're going to do one more question here. There's so many questions. Maybe we can try to get these answered after the webinar too for some of them, but there's so many questions still coming in. But we'll take one more here. Can you clarify, to assist with tricky fibrosis, were you recommending to use a pump while a patient is in their bandages for extra decongestion?
I have done that. Here's the thing though, is that if you're going to pump a bandaged patient, you want to pump them just before you remove the bandages. And because otherwise the bandages are going to get really loose, because you're going to create a really fast reduction. So I actually prefer to pump over some type of padding, and particularly anti-fibrotic padding. Like I mentioned, the Caricia is an ideal garment to pump over. So, there's lots of different ways to do it. I think that if you've got a patient in the reduction phase, using a pump on one leg while you're doing techniques on the other leg is a very, very good use of your time, because it's allowing you to treat both legs at the same time. It's multiplying your effects. So you could be reducing one leg with your hands and doing specific anti-fibrotic techniques with your hands and your instruments while you're using the pump on the other leg, and vice versa. So, I had an idea, Lindsay. If we have a lot of questions, maybe we could use that as a framework for even another webinar. I love teaching. I have just scratched the surface of fibrosis. There's so much that can be done. And I think that this was fun today, but I know that there are lots of other questions and treatments out there. So that might be, maybe look for me in the future.
Yes, definitely. And it's been such a pleasure to have you, Karen, to have you educating all of us this evening. And we want to thank everybody who joined us with all these great questions. And I definitely agree with Karen. I think there's more education to be had in the future. So stay tuned. We've got lots of comments mentioning, thank you, Karen. Thank you. It was wonderful. It was helpful. How much people love DeborahSoft for those that have used it. So all really great to see. So thank you guys for your time. Just wanted to let you know this webinar is being recorded, so we will be able to share this recording later. We will not be sharing the slides, but those slides and the audio will be tied together in the recording for you guys to be able to rewatch, to be able to relearn, and to share with others as well. So stay tuned for that as follow-up to this webinar. So thank you all for joining. Thank you so much, Karen, for leading us today in this great education. It was such a pleasure to have you guiding us tonight.
Thank you so much.